Hi guys, so I'm just going to go through hyperthyroidism because I realize in the previously posted voiceover PowerPoint there was some sort of technological glitch where you couldn't hear anything during this slide. So I'm just going to whip through it so you have the information. Same goes for this. If you have any questions, please feel free to email me. All right, so hyperthyroidism. So this is the opposite of hypothyroidism. This is where your thyroid gland makes too much of the thyroid hormone. So remember, thyroid hormone is the T3 and T4. Okay, so your thyroid gland is going to make excessive amounts of T3 and T4 when it is hyperthyroid. So with our T3, T4, and TSH levels, they're going to be completely opposite of the hypo. So if you have a lot of thyroid hormone being made by the thyroid, do you think your T3 or T4 would be up or down? So it would be up because it's producing a lot of that. And your TSH would end up being low. Because remember that negative feedback mechanism, the hypothalamus can pick up on the fact that there is a lot of T3 and T4 circulating in the blood, so it does not let a signal through to the anterior pituitary to say, hey, release more TSH because we need more thyroid hormone. It thinks they already have enough thyroid hormone because there's so much of it circulating. So they do not release a lot of TSH. That's why we end up with small amounts of TSH circulating in the bloodstream due to that negative feedback mechanism. Okay, so your T3, T4 are elevated, TSH is low. Your normal range, as mentioned in hypothyroidism, it is the 0.4 to 4.2, and that is important to know so you can recognize whether or not somebody is hyperthyroid or hypothyroid. Just looking at that TSH will let you know. Okay, so going into risk factors for hyperthyroidism. So one of the more common risk factors would be Graves' disease. Another one would be toxic multinodular goiter, simply meaning that the thyroid is enlarged and it has multiple nodules on it. And when there are those multiple nodules, it's causing an excessive production of the thyroid hormones. Toxic adenoma, so that would be a cancer of the thyroid that can cause excessive production of hormones. And then excessive ingestion of thyroid hormone. So remember, thyroid hormone, levothyroxine, is given to patients who are hypothyroid. And if they take too much of it, they end up with hyperthyroidism clinical manifestations. Okay, so those are some of the top risk factors to know about. Clinical manifestations. So again, utilize your PowerPoint for metabolism. Look at the little picture of the clinical manifestations for hyperthyroidism so you can really get a picture in your mind of what it looks like. But to go through a few here, so they have intolerance to heat, okay? They tend to have insomnia, labile mood, they're hyper excitable, kind of get nervous easily. They also will have weight loss. They'll have hypermodal bowels. That simply means having bouts of diarrhea. Their bowels motility is going faster than it needs to be. Exophthalmos, remember that is the bulging of the eyes, and that's the kind of classic sign of Graves' disease. They also can have a goiter, so I just mentioned that a minute ago. That simply means that the thyroid gland is enlarged. So hyperthyroid patients may have an enlarged thyroid. And then they can also end up with hypertension and also tachycardia, sometimes have palpitations as well. So those here general clinical manifestations. But again, take a peek at your PowerPoint slides just to get the picture in your mind. Thyroid storm. So thyroid storm is the complication of hyperthyroidism. It is life-threatening, so if it's not treated, there is a very high risk for patient death. It can be caused simply by an extreme stress to the body. So you think of things like a overwhelming infection, like sepsis, or trauma, something that is causing the body severe stress. So your clinical manifestations that you want to be monitoring for a client who's at risk for thyroid storm would be severe hyperthyroid clinical manifestations. So kind of all the things I just mentioned, but more in a more severe form. You also will see that they have fevers, high fevers, usually greater than 102. They'll also have tachycardia, hypertension. They'll have mental status changes. They oftentimes get agitated, confused, and then they're also at risk for seizures as well. So we may want to implement seizure precautions if someone is in thyroid storm. And then I did mention at the beginning of this that if we do not catch thyroid storm and it is left untreated, very high mortality risk. They can die from thyroid storm. Okay, so that's your general overview. Then your medications I want you to be familiar with. So you can see just the few I listed here, focus in on these ones. I know we talked about them in class, but just to go through each very briefly here again. So propylthiouracil. So remember, this is kind of the somewhat milder antithyroid medication of the two, and it can be given to pregnant women. And the thing we want to monitor with propylthiouracil is the liver function tests, okay, because it can be harmful to the liver. Methimazole, so this is the more potent of the two antithyroid medications. So methimazole, you want to monitor somebody's complete blood count, CBC, because remember, bone marrow suppression could possibly result from methimazole. All right, so that's something we want to be monitoring because it tends to be a little bit more potent, and that cannot be given to pregnant women. Then we have our saturated solution of potassium iodide. So this is your SSKI. Remember, this is the medication that can be given a few weeks before a thyroid surgery. Because remember, your thyroid is very vascular. Remember, it has 5 times the blood flow than the liver does. So you know it's very vascular. So what this medication helps to do is decrease the vascularity. Okay, so it helps to decrease the risk of bleeding complications with thyroid surgery. So that's why it's usually given a couple weeks before planned thyroidectomies. Okay. The other thing with SSKIs, it should rarely be given through a straw. It's a liquid, so when patients take it, they should drink it through a straw because it can stain their teeth. And then the fourth one here, radioactive iodine. So radioactive iodine, remember, can have the side effect of causing the changes in taste, or sometimes like a metallic taste to patients who are taking it. So that's just something we want to educate our patients about if they are receiving radioactive iodine. All right, so those are the medications I want you to be familiar with, because those are sort of the general hyperthyroid medications that you may see more commonly. Then another treatment option that we have is thyroidectomy. So remember, thyroidectomy is removal of the thyroid. It can be subtotal or total. So subtotal means that they only take part of it out, and total meaning they remove the whole thing. So when someone has a thyroidectomy, you really want to be sure that you're monitoring them closely afterwards for complications. Okay, so remember your slide in the metabolism lecture that has the little mnemonic of bow tie. That's just a helpful way to remind you of the important things to assess for after a patient's had a thyroidectomy. So to briefly go through those, B would be standing for bleeding. So remember, this is a very vascular gland. So there is risk for bleeding after a thyroid surgery. So we want to monitor around the insertion site. We want to monitor around the like upper chest area, over the shoulders, even kind of like towards the back of the neck sometimes. Because if someone is bleeding underneath the skin there from surgery, a hematoma could develop. All right, so you might notice some like bruising, like ecchymosis type appearance. You may notice a hardening of the skin around that area. And if that's happening, that could put a patient at risk for that hematoma applying pressure to their airway. Because remember the area we're talking about, it's the anterior neck. So if a hematoma is developing there, it's putting pressure on the airway, that puts the patient at risk for airway obstruction. Okay, so we would definitely want to monitor for bleeding. There should not be a lot of bleeding after a thyroid surgery. Okay. Open airway is next. So O stands for open airway, just simply because of where the surgery is taking place. So remember, your thyroid gland is anterior to the trachea, and when patients have surgery here, it sort of irritates the area, and the patient could possibly end up with some swelling in that area after surgery. So again, you want to monitor to see if there is swelling, that it's not compressing their airway and blocking or obstructing their airway. So we want to be listening to lung sounds, ensuring that their airway is patent and open. W, so W stands for whisper. So again, thinking of the location of the thyroid, it's right by the larynx, and it is possible during surgery that the larynx would possibly be injured. So if the larynx is injured during surgery, the patient's voice is not going to be normal after surgery. So we always want to recommend that they rest their voice after surgery. We really don't want them talking too much, because again, we're trying to rest that area in the anterior neck, and a lot of talking can just simply irritate that area and cause more like swelling, irritation. So we really try to tell these patients not to talk that much after surgery if they don't have to. But we do want to assess that their voice is still normal, that there has not been any damage to their larynx. Okay, so that's why we say whisper, because we do want to assess their voice, but we don't want them talking too much. T is for trach. All right, so we always keep an emergency trach set at the bedside, and this is because of the risk for airway obstruction. And if their airway were to become obstructed, they may need an emergent tracheostomy placed very quickly by a surgeon or physician. So that's why we always keep a trach set at the bedside in case of airway obstruction. Then I would be for incision, so we want to assess the incision. So the incision line is going to be in the anterior neck. I already mentioned earlier, there really shouldn't be much bleeding in that area, so we want to assess its appearance, and we also want to ensure that the patient is supporting their head and neck adequately. All right, so usually we have these patients sitting up in at least a semi-Fowler's or Fowler's position, and we have pillows to support their head and neck so that they do not hyperextend their neck. Because remember, hyperextending their neck is going to pull on that incision and also irritate the area. So head and neck, have it supported assess your incision to ensure that it looks well approximated, that there's no bleeding, no irritation, signs and symptoms of infection, etc. And then your E. So E stands for emergency. So remember, your thyroid gland has 4 little parathyroid glands behind it. When someone has a thyroidectomy, there is a very high chance that the parathyroid glands are possibly even removed along with the thyroid, or they could even be possibly damaged by the surgery. Okay, so if someone maybe has just had a subtotal thyroidectomy and they still have some thyroid gland, it's possible that the parathyroids behind there could have been damaged during surgery. And what happens when we have damage to our parathyroid glands? Well, think back to lecture. It has to do with regulating your calcium levels, right? That's what the parathyroid glands do. They regulate calcium levels. So if we have damaged the parathyroid glands, we are at risk for hypocalcemia, so low calcium levels. Okay, so we want to observe our patients to look for signs and symptoms of hypocalcemia. So that would be things like the muscle twitching, tetany. They may complain of numbness or tingling in their hands, sometimes around their mouth. They have the positive Shovstek sign and positive Trousseau sign. Okay, so we want to be looking for those signs and symptoms of hypocalcemia. And if they do have low calcium levels, we need to treat that. So we administer calcium gluconate or calcium chloride, something to bring that calcium level back up into normal range with a goal between 9 and 10. So that would be your emergency. So that, again, is just sort of an overview. I know you have the little picture in your PowerPoint from metabolism, so whatever helps you most, use that as a visualization, or jot it down here in your little concept map box if it helps you to do that, for studying, whatever works best. And then lastly, so your nursing interventions. So thinking about diet for these patients. So you want high calorie, avoid caffeine. Remember that these patients basically break down their nutrients too fast because their basal metabolic rate is accelerated. So they could very easily end up malnourished because their body is just using up too many of the nutrients too fast. They're really not absorbing it well. So that's why we want them to have like high calorie, well balanced diets. We want to ensure that they are not becoming malnourished. And avoid caffeine because remember, caffeine is a stimulant and that's just going to increase your basal metabolic rate. Environment. So thinking about their hospital room, for example. You want to keep their hospital room nice and cool because they are intolerant to heat. And you also want to keep it calm in the room, low stimulus. Because remember, these patients are hyperexcitable, they're a little bit labile. So we want to keep the environment nice and calm, decrease the stimulation as much as we can, keep it cool, just provide them with light layers of clothing, maybe just one sheet, things like that, to accommodate their clinical manifestations that they're going to be experiencing. Then their activity levels. So you want to provide frequent rest periods, especially if they are experiencing like tachycardia and hypertension. You really don't want them using up more energy and putting more demand on their heart if they're already tachycardic, etc., from their hyperthyroidism. So you try to get them to take some frequent rest periods, pay attention to their bodies and their symptoms, and allow their body to sort of slow down a little bit here and there. Then your interventions for thyroid storm. So thinking back to when I just talked about thyroid storm and all those clinical manifestations. So what are we going to do for them? Well, For one, we are going to ensure that they are oxygenating well, because remember, their supply and demand may be altered in this thyroid storm state. So you want to ensure that they are oxygenating well, maybe apply supplemental oxygen. You also want to monitor their vital signs, because they're going to be tachycardic, hypertensive. Remember, we can give propanolol for that. Propanolol is a beta blocker. It can help with those symptoms. Also reduce the body temperature, because these patients will have high fevers. So we want to reduce their body temperature, but we do not want to do so in a way that it causes shivering. Because what does shivering do to our basal metabolic rate? It increases it, right? So we reduce their body temperature, but we avoid causing them to shiver, because that will just make their metabolism go even faster when it really doesn't have to in this situation. Okay, it's already dangerously fast. Other things would be giving antithyroid medications. So we need to get the production of the thyroid hormone under control, because this thyroid in this state is making way too much of the thyroid hormone T3 and T4. So we need to administer their antithyroid medications and suppress the amount of thyroid hormone that the thyroid gland is secreting. Okay, so those would be our main goals of care for someone in thyroid storm. Okay, so that is hyperthyroidism in a nutshell, to talk about the important things that you really should have a good understanding of going into the final exam. The desired client outcomes, same with this one. I'm going to let you come up with those yourselves, because I want you to apply your knowledge that you just received from this short recording, or from your lecture, from your notes, wherever it is, and apply your knowledge as to what would be your goal for these clients. What would these outcomes look like for a client with hyperthyroidism, based on everything that I've explained here and what's going on with their body. All right, so that's it for hyperthyroidism. Sorry, I had some difficulties with the previous recording, but hopefully this one will work just fine. If you have any questions, feel free to email me. Thanks.